Hello and welcome everyone. My name is Lisa Collins, UBA's Director of Strategic Solutions. On behalf of United Benefit Advisors and Lucent Technologies, our guest today, we want to welcome you to today's presentation in the UBA Employee Benefit Monthly Webinar Series. Today's topic is 3 innovative ways to use self-funding to reduce your medical costs. We have 2 speakers today I want to introduce to you. Alex Arnet is the Chief Commercial Officer of Lucent Health Solutions. Alex has a history of developing and implementing highly effective growth strategies with a keen focus on innovative health risk management solutions to deliver the most affordable plans to employers. In addition to Lucent, Alex has 30 years in a career in healthcare industry. His successful track record growing companies includes his early career as an underwriter and sales leader at Prudential, a senior sales leadership role at United Healthcare, Great West Healthcare, and HealthSmart. Our second speaker, Justin Meissner, leads sales for Lucent's office in Denver, Colorado, focusing on captive insurance sales, reference-based pricing, group sales, and overall self-funded benefit plans. He helps educate companies of all sizes, from 50 employees to thousands of employees, on their options for customizing employee benefit programs specific to their population needs. Working in the TPA business for the past 6 years in high-level sales roles, Justin brings strong employee benefit knowledge and training to his position at Lucent. So Alex and Justin, I'll turn it over to you.
Thanks, Lisa. I do appreciate it. I hope everybody's having a good day. Listen, we're going to be taking a very high-level approach to the 3 innovative ways to use self-funding to reduce medical costs. And so the agenda is pretty quick. We're going to talk about what's the problem, what are we trying to solve, what's the best way to find the right TPA or third-party administrator to help you do these innovative solutions, and then what are the unique ways that you can control costs and minimize the risk on your self-funded plan. And then other things, talk about other programs that you can put in place to minimize any kind of disruption and enhance the overall member experience. So high level, and so we hope you find this very informative. I don't think it's anybody's secret here that we all know what the problem is, right? Over the last 20 years, 400% increase in total costs. And hospitals, for example, are charging anywhere from 300% to 1,100% of Medicare. So the biggest problem that we're going to be discussing today, a lot of it is how do we control hospital bill charges and costs, and how do we actually give you 30% savings. So we hope you enjoy the information we provide.
Yeah, thanks, Alex. And we feel that self-funding is really the first domino to fall in terms of really taking control of your healthcare spend. And making sure that you have the flexibility and customization in order to do that. We feel that you should be working with your UBA advisors to properly evaluate the right TPA to work with. And there's a difference between an independent TPA and a carrier ASO TPA. Independent TPAs really offer that level of flexibility and customization and plan design, as well as vendor selection and so on and so forth, to really build the plan and customize your solutions to meet your specific needs. And some of the things that we're going to talk about today are 5 things to evaluate TPAs and what you should look for when you're looking at TPAs with your UBA advisor. And this slide really just tells you that self-funding is working. And there's a lot of folks out there that are doing that today. Over 94 million of the 165 million employers or employees, I should say, in the US are either partially or fully self-funded. And oftentimes employers, when they're evaluating TPAs, they're really looking at a small portion of the overall pie. And that's the fixed cost, which is only about 20% of the overall plan spend. And when you really want to control cost, you really need to look at that other 80% to really have a major impact. And some of that 20% of the cost is really made up of the fixed cost. That includes administrative fees, stop loss premiums, and we'll talk about stop loss here in a sec. But again, that's really a small portion of the pie. The other 80% is the variable cost, is the claim spend, and things that you can really control by implementing different unique solutions like cancer programs, diabetes programs, really taking care of the sickest of the sick population, the 10% that's spending 80% of the plan spend. So a few things that we feel like you should keep in mind when you're looking for TPAs and evaluating those TPAs out in the marketplace are as follows. And I think the first one is really education, and that's from the employer perspective, right? You need a TPA that's going to help you stay up to date on all the constant changing legislation, regulations, and things that are going on in the healthcare marketplace. I always like to use the analogy, it's sort of like Charlie Brown's teacher. If you're not in this every single day and understand it and know it, then it's kind of it's want, right? So you need a TPA that's going to be there to help you stay in compliance and educate you on different solutions in the legislation that's happening. The second piece is the risk mitigation, right? We want to fundamentally help drive down the risk of your self-funded health plan, and really that's taken on, like I said, the 10% of the population that's spending 80% of your plan spend. That's the sickest of the sick, the members that really need help and guidance when healthcare happens. And so you need a good TPA that's got integrated care management and concierge solutions to help with those types of members. The third piece is more from a member perspective. It's the decision support piece. And that's when the concierge comes in, really holding the members' hands when healthcare happens, helping them become smart consumers of healthcare. Because at the end of the day, it's the plan's money. And so if members have that mindset of, hey, if we do good and be smart consumers of healthcare, we can help drive down the cost of the plan. And in turn, we can save money ourselves. And then the fourth piece there is the integration aspect. And we like to consider that more of the gold plan. And that's really having a TPA that knows and has these integrated systems and processes in place that makes the administrative aspect of that super seamless and easy. Because we also want to take the burden off of the HR staff. We don't want members coming into your office complaining and saying, hey, we don't have benefits, or we don't have providers to see, or a claim's not being processed correctly, whatever it might be. We want to make sure that that's super seamless and fully integrated, because as a TPA, at the end of the day, we move money, we process claims, and we answer phones, right? We got to have the best in class services, and you have to be perfect at the basic blocking and tackling, because at the end of the day, the TPA is only as good as the last claim that they paid. And then lastly, but certainly not least, is the cost reduction, right? We all want to make sure our members are happy, of course, but we definitely want to make sure that we're helping you control cost and reducing the overall cost of the plan. And that's really just by understanding your plan and your specific needs, and focusing on implementing those cutting edge, unique cost control solutions to drive down the overall cost of the plan.
The one thing I would add to add what Justin just said, when you're looking at a TPA, it's very important to find out their level of experience, how long they've been in business, what type of technology do they have in-house, and what type of kind of concierge, care management, contracting, what type of tools do they have in-house or the outsourcing? In many cases, you're going to want to find those TPAs, those third-party administrators that have those as in-house solutions, and they're not what's considered a bolt-on. And the more experienced, the more integrated, the more in-house, the better the experience for you, and quite frankly, the better experience for the member.
Perfect. Thanks, Alex. And we'll talk to you a little bit more about some cost control and risk mitigation strategies, things that you can do to, like we said, really drive down the cost of the plan and fundamentally drive down the risk of the plan. So the first thing you want to look at is really the plan design, right? Design the plan around mitigating the risk, and some examples include, making sure that you're driving employees to and incentivizing your employees, like, for example, to quit smoking or behavioral health and improving in their wellness and stuff like that, that will result directly in savings for your overall plan. The second piece is, like I said, prioritizing the catastrophic care and preventive care for some of those high cost claimants and the members that really need the most care. Like we always say, hold their hand while healthcare is happening. And that's really going into the 10% of the population that's spending most of the plan spend and coordinating those plans and prioritizing preventive care. We always like to say that the best discount is 100%, right? If we could prevent those members from going to the hospital in the first place, be proactive in getting engaged with them to get them and keep them healthy, that's where the rubber meets the road. And designing plans with that in mind is really going to help you get to the end goal and controlling those costs.
The other thing too is if you're going to be offering really innovative solutions that, one, help your members have a better healthcare experience and a better outcome, which will reduce costs. In some cases, you don't be afraid to offer free benefits to incentivize them into those programs, because in most cases they're going to be cutting your costs, your claims expense by a massive amount. And so why not incentivizing those folks to go ahead into those programs and get them to use it in Money Talks?
And so, Alex, would you like to touch on the stop loss piece and making sure that that's in line?
Yeah, this is critical, folks. There are plenty of stop loss insurance companies in the United States offering coverage, but sometimes the cheapest isn't the best. The old adage, you get what you pay for. So make sure when you're working with your UBA advisor, and by the way, they're experts at this, and they will help you through this process. They'll get you the best insurance company that has a great reputation, the great reputation for processing and paying claims. But it's critical that you make sure that that stop loss coverage matches exactly what your program, how it works, the programs you have in place, and the benefits. And when you do that, that'll eliminate some heartache down the road. But take the extra time on the stop loss insurance coverage when you're completing the application and going through that. Make sure the T's are crossed and the I's are dotted. Take the extra time. Yeah, here's a good thing. As it relates to claims data. Many of you, I'm not sure, some of you may be fully insured, some may be self-funded, but when you are looking at a TPA, any TPA, whether it's carrier owned or an independent, make sure they have their own in-house technology. And the fact that you have access to that tool and that data has deep data, meaning it has hover technology where you can drill down into the information. There is a massive amount of information in your claims detail, whether it's medical or pharmacy, where you can actually drill down to find out what is driving some of your costs, and make sure that, quite frankly, it has benchmarking information. For example, do you have issues? You may want to drill down and find out you got a lot of emergency room utilization. Make sure that whatever tool you have allows you to get to that level of detail, because that then gives you a chance to change the benefits or design your benefits in a different way to incent your people to move more into, say, urgent care as opposed to emergency room. So the amount of data that you have access to is critical. Make sure you have a demo and you get a chance to look at the tools that are available to you, because it's critical and will help you save money. And you can drill down to all sorts of things, including your pharmacy spend, and you'll be fine. You'll be shocked at how much savings you can find on the pharmacy side. But the tools are important. Make sure that you take the extra time to learn that before you make a decision on selecting a TPA.
Yep, absolutely. And that data has to be meaningful and actionable, right? You can have a bunch of information and not have anything to do with it or not know what to do with it. You have to understand where your money is being spent. And so that data will allow you to do that and understand what's really driving the cost of the plan in order to understand and have an idea and strategy of what solutions you can plug and play.
Another thing that's critical on your data, if you're with a carrier today, in most cases, by the time you get your claim reporting, it's over a month old, sometimes as much as 2 months old. If you're going to go and look at a TPA, make sure that whatever technology or a data analytics platform you're looking at, the data is up to date through the day before. That is what you call near-time data. So make sure that that data is being updated either daily or nightly. So anytime you're going in and you're looking at your monthly reporting package, which is updated through the previous date, that then also could be used to match up against your income statement, and make sure that those tools have the information so that, quite frankly, whatever you have built into your budgets is also appearing on your claim reporting tool from the TPA. There's some great stuff, but make sure they have the basic fundamental data there, and make sure the data is fresh. Data gets old fast, especially after 30 days. Make sure they're doing nightly feeds or daily feeds. It will save you a lot of time. Plus, it'll help you with from a budgeting perspective and making decisions, even if you try to do something mid-year.
Yep, absolutely. And that'll also allow the care management team and case managers to really get engaged more early on and proactive, right? We can get, like I said earlier in the presentation, if we can be preventive and getting engaged with those members and preventing them and avoiding them from getting to for example, catastrophic stage 4 cancer situation, we want to make sure that we're proactive with that. And that nightly data feed allows TPAs to do that. For example, there might be a member that goes into a doctor's office and they recommend going to an MRI center that's attached to their hospital or whatever it might be. They could be charging $600 to $1,000 or something like that. But if we can get engaged early on and we have that data immediately and nightly, we can reach out to that member, help steer them to a less cost, higher quality facility, and everybody wins in that scenario, right? So that nightly data and that timely data is crucial. So now we're going to talk about a few cool and unique solutions in different ways that you can really help control costs and while at the same time really taking care of your members. Some of those solutions include reference-based pricing, for example, and we'll take a little bit of a deeper dive into that. Direct contracting, narrow networks, some value-based network options, and then other types of value-based options, including telemedicine and direct contracting and stuff like that. So we'll talk a little bit more about that here in a sec.
Let's talk about reference-based pricing, what some people call RBP plans. For example, our organization, we administer all sorts of plans, traditional PPO plans, and narrow network plans, but we also administer quite a few reference-based pricing plans. But here's the problem you're trying to solve, and I mentioned it a little bit earlier, right? The average bill charges from the hospital, because right now we're focusing on facilities and hospitals and their costs. And by the way, remember, hospital claims represent roughly 25% of the number of claims, a little less than that, but they generate almost 80% of your total spend. So the focus, you're pulling a big lever here from a claims cost reduction perspective. So if hospitals are charging 500 to 11 times, and sometimes even higher, depending upon the region, and you're only getting, say, a 50-55% discount, because that's the national average based on all the information we have with all of our TPAs, which includes Cigna, Aetna, and Blue Cross Anthem. After that, you're still paying 2.5 to 5.5 times Medicare. Very expensive and unsustainable over time. So what is reference-based pricing? It's basically, we're going to be using Medicare as your baseline because the government has the best price in the United States. And you're basically going to pay 140% of Medicare is your target for all of your hospital claims. That's generally what you're going to be focusing on. And when you do that, right, our overall experience has been, because in some cases you will negotiate above 140. On average, our results are 160. You will see a 30 to 35% reduction on an RBP plan over a traditional PPO plan. So it's a very good tool. Your UBA advisor will know about these programs that may or may not be a fit for you and your employees and your members. But if you're looking for ways to greatly reduce costs, this is a very excellent tool. And we'll talk about what are some of the best practices when you're doing RBP plans. All right, so what's the best way to do it? At the end of the day, you're going to use the target of 140% of Medicare, because that's the best way to do it. And you're going to just be focusing on hospitals. In essence, your employees will have access to all hospitals, and we're going to be repricing those claims at 140% of Medicare. Note, on most really good RBP plans, we have over 100,000 members ourselves, and there's a lot of good TPAs that know this space. You're going to be using a physician network will be a part of your program. So 75% of your claims, which represent 20% of your total spend, for like office visits, urgent care, those types of things, you'll still have a physician network, and you'll want to have a physician network. If you go full RBP, then you're doing our reference-based pricing for hospitals and doctors. We don't recommend that. We recommend using a physician network for those types of things, for the doctor visits. Use reference-based pricing for hospitals. So that's step one. Two, if there's an opportunity and you have a large concentration of people in a particular area, and the TPA has let's say a direct contracted network, or you have access to a highly effective direct contract, a large hospital system in a major metropolitan area or others, we would recommend that you would include that as part of your program. Because when you get those types of programs, you're still getting significant savings, right around 180% of Medicare, which will still drive 25%. Include those where you can. Next, you must have an integrated concierge care program. You cannot just have traditional customer service. You need a concierge care team that is very experienced in RBP, and they will hold the hand for your employees. And when you do these types of programs, your goal is anytime they have questions about their plan, they should be able to go to concierge, and that concierge team should be able to answer all their questions, including if there's a balanced bill. And we'll talk about that in a minute. The other thing we recommend, make sure that TPA, the first step would be make sure they own it. If it's owned and integrated along with the care management, where you're doing the hospital pre-certification, large case management, all those big claim stuff, make sure it's already integrated. That way, everything is in one system and the member has one place to go to get their healthcare needs taken care of. So make sure it's fully integrated, care management's integrated, and make sure there's a balanced bill protection component. And we'll talk about that in more detail in a minute. And then another key is, do they have a good member education process? Because if you went from a traditional plan to an RBP plan, you're going to need to be able to educate your members. There's a lot of different things you do, like drip campaigns in anticipation of making this change to an innovative plan. Make sure that that TPA and your UBA advisor will know what works, what doesn't work. We'll work with the TPA to make sure you have a good communication plan. So when you move to the new plan, you'll actually have a smoother transition so you can capture the savings, less phone calls to HR. Last, I'm going to talk about dual option, but dual option is another key thing that's important. And I will tell you, per Benefit Pro, which is a national periodical, today there's about 5% of people are basically RBP. They're projecting in the next 2 to 3 years, it's going to go up to 20%. So this thing is continuing to grow in a very fast way. So dual option, what does that mean? All I'm saying is that you would offer your employees two options. You would have an RBP plan, which has the lowest cost to them, lowest cost to you, with the best benefits. And then you would offer them a traditional plan, a PPO plan, Cigna, Aetna, Anthem, Blue Cross, whatever, is option 2. Higher costs, lesser benefits. But it gives those people who want the comfort of a traditional plan, has the access to it. By the way, our experience has been 75% of your people will select the RBP plan, 25% will select the PPO. And I always tell people, most of the people that select the RBP plan are not really utilizing the plan as much. When they do, you get awesome savings. But why pay full rack rate for all of your people when you got a lot of people that would select that lower plan? And if that plan's done right, you capture the savings and everybody wins. So dual option is all we're talking about. Is RBP is option 1, PPO plan is option 2. And your UBA advisor can help you and design the right plan to encourage people to go to the right program and help you set your contribution levels. So that's what a dual option plan is. All right, let's talk about the boogeyman in the room, because I'm sure some of you have heard about RBP and you heard, oh my gosh, balanced billing is terrible. It's 30%. Folks, it's not. Balanced billing, when it does happen, is noisy. And by the way, if you're on a traditional plan today, you get balanced bill today as well, just so you know, it does happen. In the case, our experience in the industry level, our balanced bill rate's 2%. And that's because we're doing it. We have you have to have the concierge, integrated care management, all those pieces are there. Then you'll get to a 2%, slightly less than 2% balanced bill rate. And you can see from this corridor, this pie chart, that basically most of, not all of them, get negotiated well below 200% of Medicare. Occasionally a balanced bill will get negotiated above 200% of Medicare, but you're still ahead of the game. Because remember, the average is probably 250 to 350% of Medicare on a national average perspective. So if you have all the pieces in place, the balanced bill rate's about 2%, a little less. And if you have all the tools in place, they get resolved very quickly. But there can be some noise. I don't want to say that there isn't, but you will, if you do it the right way, you're going to get 30 to 35% of savings. All right, here's a great example. Now this kind of we wanted to give you kind of the shock and awe approach. So if you do RBP, now this is one of our clients that came on in 2018. They do have 1,500 employee lives. Not all of you do, but in this case, they basically, over the last 5 years, have saved $22 million over their previous Blue Cross and Blue Shield plan. and it's year after year. And the good news is you can see what their total cost and spend has been. You can see the trend is much more under control than the national average, which is anywhere from 9 to 12% per Milliman and Mercer. So that's a big number. Just remember, if you're going to figure out what your savings might be, just take 30% off of your current spend, and that would give you a rough idea. But again, work with your UBA advisor. They can help you really understand what the savings will be and if it's the right move for you.
Yeah, so we know that RBP works. It helps savings, right? It helps you save money. A little bit disruptive. It could work for some employer groups and maybe not so much for others, right? A recent study from a really renowned RBP repricer, the Arnet company, showed that over 90% of employer groups out there said that, hey, if we get 25 to 30% of savings, heck yeah, we're going to explore this option. But you want to make sure it's a right fit for you and your population. And again, your UBA advisor can help you do that and do some experience reports based on your population and where everybody resides, and really just make sure it's going to be a good fit for you. And just to kind of back up that survey, just kind of here's some stats from the Arnet company, where obviously 51% they're very interested. A lot of them are somewhat interested there. Some are like, yeah, I don't know. And then others, obviously if they're like, hey, this is too risky, too much, not something we really want to get into. But a majority of the population out there is very interested in RBP plans.
If this puts you any kind of perspective of what's happening in the market, 9-10 years ago, we didn't have any RBP business as a national independent TPA. Today, half of our 200,000 members are RBP or RBP dual option. And every year that number continues to slowly grow, and it's starting to even grow at a more rapid rate, because now we're seeing not only groups that are generally, say, 50 to 150, which were the original adopters. Now you see a lot of larger employers are moving into it because, one, it works, and two, the savings are immense.
And just to recap, the things that you need to have in place for an RBP plan to work. Number one is member concierge. That's where the rubber meets the road. Cutting edge care management. You got to have that in-depth integrated care management piece. Do a little bit of direct contracting. If you know that a lot of your population is going to a certain facility, maybe we have the TPA reach out and get a direct contract in place to minimize the disruption. Dual option as well, like Alex had mentioned, really does help employer groups take on these types of model. Makes it a little bit more palatable for the employers, and also to minimize that disruption at the end of the day. And last but not least, having that balanced bill protection in place. And obviously, RBP is a little bit more on the aggressive end of the spectrum in terms of cost control. But if you don't want to take that giant leap to RBP, you don't have to. There's other solutions you can deploy that can help you control costs, right? And these can be bolt on to just a traditional self-funded plan. So for example, direct contracting, like we mentioned, on-site, near-site employer clinics, right? Makes it easy for your employees to access care, that primary care. True direct contracting, like I just mentioned, if you have a lot of volume going to a certain provider, then have that TPA go in and write a direct contract, establish a direct contract. And oftentimes that's going to be way better than any network discount that you can get, because that direct contract's in place. And then lastly, just some narrow network options. While it is a little bit less options for your members, it's going to be deeper discounts and oftentimes higher quality care, right? So you're going to have more comprehensive options, albeit it's going to be narrow. These are easily able to bolt onto any traditional self-funded plan using any Cigna, Anthem, Aetna network, for example. And then you have multiple options to build that plan to help steer those members to that narrow network as sort of a tier one, if you will. So these are just different solutions outside of RBP and just being super aggressive that are more of a baby step to control your costs. And you can oftentimes get these from any independent TPA, or your carrier may also offer these as well. So outside of that, there's also other different solutions you can deploy.
Hey, one thing I was going to make mention too, when you are talking to an independent TPA with your UBA advisor, not all TPAs are created the same. So each TPA may have access to different network options, whether that's a traditional PPO network through, say, like a United, Cigna, Aetna, Blue Cross. And many of those organizations do have narrow network options that are very, very effective. And that way, by going to an independent TPA, You can then unbundle and do some other things like on pharmacy and really start capturing some other areas that are out of control from a cost perspective. But make sure you understand what is available to them. Also, make sure that TPA, especially if you're looking at more of these innovative plans like RBP or direct contract or narrow network, make sure they have in-house contracting capabilities, because oftentimes you're going to want them to be able to do that for you. And if they have it in-house, it's a plus. And not everybody does, but it's one of those things that as you're making that selection, I would definitely work with your UBA advisor and make sure that they do. And I think that'll be an enhancement. And plus, many of the RBP repricers that are out there, and there are several, many of them have developed their own narrow networks in markets like Texas with Baylor Scott and White. Down in Florida, you may be looking at Orlando Health or Advent. Up in Wisconsin, it may be Aurora. So each of these RBP repricers are not the same either, because they may have narrow networks already contracted that may be perfect for you. And that way you can do the narrow network where there is no balance billing, still do RBP and still do dual option. But again, make sure that TPA has access to those networks and or RBP repricers and has their own in-house direct contracting capability. I think it's critical. Go ahead, Justin. I apologize.
Yeah, no, absolutely. I appreciate that, Alex. Yeah, just to kind of close out some of the additional solutions you can deploy, specialty RX, specialty drug carve-out programs and international outsourcing. I mean, we all know that, healthcare spend is outrageous. And the specialty drug spend is over half of that entire spend. It's the leading driver of any health plan. So if you can deploy solutions like, carve out specialty drug programs, patient assistance programs to get those high cost drugs at a fraction of the cost, and get those members qualified and enrolled in those programs, that really is impactful in controlling your RX spend. Another piece.
Justin, let me make a key point here, folks. Every one of you on this call has a specialty pharmacy cost problem. So 1% of all prescription drugs that get prescribed and taken, 1% are specialty. That 1% drives 50% or more of your total pharmacy spend. So by doing these specialty RX carve-outs, you can reduce your pharmacy spend by 50% in many cases. And by the way, reduce the out-of-pocket expense for your member. This is a key item, and you should be exploring this and talking to your UBA advisor. They know all about fees. They'll be able to help you understand it. But by just doing this one thing, you can do traditional network and do a transparent pharmacy program with the specialty carve-out for the specialty and some international. That by itself would probably help you reduce your spend by 12.5% to 15%. So that one, that we have it on the top of the list because that's a big one. And your UBA advisor will be able to help you understand how to do that. And sometimes the only way to do that, if you're fully insured, you got no chance to do it. But if you go to a self-funded, you go to an independent TPA, oftentimes allows you to unbundle that component and put the right program. You will get savings. They're big, and it will be a huge plus, especially to your people that are already on these specialty drugs. And if you're on a high deductible plan where they're paying $6,000 a year just for that drug by itself, you may be able to get that for free or near free. So it's a big item. So one thing, a big takeaway for today, talk to your UBA advisor about specialty pharmacy and transparent pharmacy. It's important.
Yeah, absolutely. And some of the, just to close it out, some of the other solutions, surgical networks, right? Bundled pricing for some of the, optional procedures, the non-emergent elective procedures that you can actually shop for, right? Like a knee surgery or hip replacement, stuff like that. There's vendors out there that will allow you to go to a provider that's a bundled price, which includes pre and post-op care, the anesthesiology, everything that goes into that procedure in one bundled price. And oftentimes that's a fraction of the cost. For example, you can go to XYZ facility, get that done for say $5,000. Well, this bundled price allows you to get that done at a fraction of cost at say maybe $1,000. And a lot of the employer groups out there are actually incentivizing their employees to go to these facilities versus maybe an inpatient facility because at the same time the plan wins, they save a lot of money on that procedure, and the member wins by way of waived out-of-pocket, waived copay, waived deductible. They essentially get that for free by way of going to that facility. So great solution there. That also works with diagnostic imaging, any MRI, CT scans, stuff like that. Another piece is using centers of excellence, really high quality providers for things like transplants and cancer care, right? And then dialysis programs. For example, there's programs out there that offer dialysis treatment at a percentage of Medicare, like we talked about with reference-based pricing. You could deploy those and just these simple solutions to really attack and drive down the cost of those high-cost types of procedures and high-cost claimants. Employee assistance programs as well, direct primary care, where you can get engaged with the member and really control and steer them from the ground floor. Some of the primary care physicians out there literally just send the patient over to one facility just because it's their dad's golfing buddy or whatever it might be. And sometimes that's astronomical. And if we can help steer them from the direct primary care, which is incredibly high quality and attention to those, gives attention to those members by spending time and getting to know them. So if we can steer them from that level and away from the high cost and low quality facilities, that's where you can really have an impact with the membership and controlling costs. So obviously, anything that we talked about today, get with your UBA advisor. They can help you out and explore any of these options. And at the end of the day, you can do it. You can take control of your healthcare spend. You don't have to stay status quo. If you really want to control costs and take care of your members, you can do it.
Yeah, we appreciate your time today, folks. Your UBA advisors, they're all experts in this area. And again, when you're interviewing and when you're talking to TPAs, make sure they have the experience, the integration, and the technology and the in-house capabilities so that you can execute on innovative health plans and you can be successful, controlling costs, deliver better benefits, and quite frankly, deliver lower out-of-pocket expenses from a contribution expense perspective for your members. So we appreciate your time and hopefully today was helpful.
Thank you, everybody.
It was 30,000 feet, but we hope we got the juices flowing.
A lot of great information. Thank you so much. With all of the different solutions that you just shared, can you give us an idea of average size group, a certain industry that this fits well with? What do you see?
Yeah, I would tell you this. On average, for these types of plans, probably the average employer size is probably still between 150 to 200 employees is what we would see on our book. Now, we do have clients that are as big as 10,000 employees that utilize this, but our average size for this type of program is probably around 150.
Yeah, and I will also add to that, there's a lot more employer groups out there, even on the smaller spectrum that are starting to explore this because, quite frankly, the healthcare costs are getting out of control and they need a solution, right? And so we've got employer groups down to 50 lives. It's a little bit more difficult because one bad apple can spoil it all, right? If you have a few high cost claimants, there might not be a lot of stop loss carriers out there that want to take on that risk, but there's different solutions and types of models like level funding, for example, to help those kind of smaller employer groups take that baby step, get some claims data, some transparency, and understand where your money's being spent, and then potentially make that move to traditional self-funded later on down the road once you have an understanding of where your claims dollars are going.
And what kind of time frame does it take to implement this?
The more time, the better, I would say. So listen, if you're going to be putting an innovative plan, give yourself more time because you want time to start you got to get educated along with your UBA advisor is going to do that and the TPA will work with you. But I would say give yourself at least 90 days to implement these plans. Most TPAs and UBA advisors, they know how to do this because they're experts at it, can do it in 60 or less. But give yourself 90 days if you're going to be putting in some cool, innovative solutions, just so you can get your people ready to go. And the other thing too, I would tell you, it's critical. We didn't talk about it. Make sure the technology that's available to you, whether it's a carrier or a TPA, the mobile technology, so you have a mobile concierge, make sure that is really strong because you want the member, because everybody operates off of that. Our average download rate is like 80% on our mobile app. Make sure you have those types of download rates because otherwise they're going to call you instead of going to their app and then coming to us as the TPA. Get a strong technology, strong concierge. That reduces the amount of time and energy you have to spend to explain because all that information is going to be right there and you don't have to re-explain it. It's super easy and there's some great tools out there in that area, especially even if you had to get something else that bolted on, tons of cool tools on the mobile app side.
All right, thank you so much. And of course, we've gotten the questions, and we probably should have said this at the beginning, but yes, you will get a recording of this presentation. So thank you, Alex, Justin, for all your expertise sharing that with us today. I want to thank also the UBA partner firms that have joined, the employees, the clients. Next webinar will be on Tuesday, always falls on a Tuesday, April 18th. And the topic will be practices in paid parental leave. Unum is presenting this. Unum is a valued UBA alliance as well, offering, gosh, a whole bunch of things: dental, vision, disability, life, cancer, accident policies, hospital indemnity, but also absent management services and mental health benefits. So you can contact your UBA partner advisors for more information on that, but please join us next month, April 18th, for that. Thank you again for participating in the UBA Compliance Monthly webinar series, and we'll see you next month.
Thanks, everybody.
Thank you.
Thank you.